Good afternoon. Welcome to Samaritans Purse International Health Forum today. Thank you so much for joining us. We're excited to have Dr. Burton Lee with us today, and he is going to be sharing on an update on sepsis, new definitions, and new management guidelines. We really hope that you can participate in our conversation today. Please note that you can chat with us in the chat box beside the video, so please feel free to put your questions and comments there, and we will see them and get to them. Before we begin, I just want to open up our time in prayer today, so if you'll pray with me. Father God, we thank you so much for the opportunity to come and learn, and we just pray that you be with Dr. Lee as he shares with us today. Lord, give him the words and give our minds understanding to learn and grow today, and may this impact our practice and the way we do things, Lord. In your name we pray, amen. All right, as we get started this morning, just want to introduce Dr. Lee. He is a medical educator and visiting professor at the University of Pittsburgh. He graduated from Harvard Medical School and trained at Massachusetts General Hospital in internal medicine and pulmonary critical care medicine. Dr. Lee has served at Kajabi Medical Center in Kenya from 2010 to 2016. He trained national physicians there and clinical officers in critical care medicine. Prior to his service in Kenya, he was the director of the Washington Hospital Center for Pulmonary Critical Care and Emergency Medicine Critical Care Fellowship Programs. He was also an associate professor at Georgetown University School of Medicine and a senior consultant for critical care education at the National Institute of Health. I'm sure you will learn a lot today. So Dr. Lee, without any further ado, we're going to let you take the presentation.
Okay, so thank you for inviting me, and I guess good morning or good afternoon, depending on where you are. So I'm delighted to talk to you all about sepsis. There's changes both in the definition and the management guidelines that were just published actually about maybe a week or two ago. So I thought this would be an important topic to review for the audience who are interested in global health and international medicine, as sepsis is obviously a big part of what we see overseas. So if we could have the first slide. It's segmented into two different parts here. The first part is to go over the new definitions of sepsis and shock, and then the second part will be on the new surviving sepsis guidelines from 2016, which was just published about 2 weeks ago. So let's start with the new definitions of sepsis and shock. Start with a case. We have a 45-year-old man who has fever, cough, and dyspnea for 3 days. The vital signs reveal temperature, blood pressure 110/70, heart rate of 100, respiratory rate of 26. Patient looks acutely ill, lethargic, and disoriented. Physical exam reveals rales at the right lung base, and urine output is very low, only about 5 cc's in the last few hours. And then the laboratory exam reveals an elevated white count of 15, hemoglobin of 8.2, and platelet count of 180,000. Electrolytes show a sodium of 138, potassium 4.9, chloride 105, bicarb of 18, creatinine of 2.0, and then lactate of 6 milliequivalents per liter. Urine analysis is unremarkable, and patient samples of sputum, urine, and blood are sent for culture, but they're all not available at this time. And a chest x-ray is taken, which reveals a right lower lobe infiltrate, which is the exact area of abnormality on physical exam. So based on this patient's presentation, this patient has A, bacteremia, B, sepsis, C, severe sepsis, or D, septic shock. Next slide, please. So I think what's important for the audience to note is that the old definition had 4 different terms. The terms included SIRS, sepsis, severe sepsis, and septic shock. And SIRS involved 2 or more of the derangements in white blood cell count, respiratory rate, temperature, or heart rate. And if the derangement in those parameters, that is SIRS, was due to an infection, then the old definition said you had sepsis. Then a subset of patients with sepsis who have either organ failure or elevated lactate, you were considered to have severe sepsis. And finally, if you had severe sepsis, but you were in hypotensive shock, defined as systolic blood pressure less than 90, you were considered to have septic shock. So these are the definitions that many of us have been using for a couple of decades. The mortality, as you can see, ranges from 16% if you meet the definition of sepsis, all the way up to 46% if you have septic shock. So this patient, using the old definition, had evidence of infection and had both organ failure and elevated lactic acidosis, so would have met the definition of severe sepsis. This person would not have been in septic shock because at this time, the blood pressure was not less than 90. However, next slide, please. These old definitions have now been changed, and the new definition actually eliminates 2 of the 4 terms. That is, there is no longer any reference to the concept of SIRS, and the term severe sepsis has now been also been eliminated. So they've kept the 2 old definitions of sepsis and septic shock, but the exact definition of those terms have actually changed. So sepsis is now considered an infection, just like the old definition, but now you have to have a dysregulated host response resulting in organ failure. So it is similar to more of the old severe sepsis definition. And then septic shock has been changed to not just somebody who is hypotensive, that is systolic pressure less than 90, but has now been now includes a definition of requiring vasopressors and an elevated lactate. So it's not just hypotension anymore, but it's hypotension plus lactic acidosis. And the new mortality rates that are calculated with these definitions are 10% for sepsis and 40% for septic shock. So this patient, then, you need to calculate an organ dysfunction score to figure out whether they have sepsis or not. And so the next slide has the SOFA criteria table. So the table is reproduced from the article in JAMA that talks about this. So score is from 0 to 4, as you can see on top, and it is measured along 4 criteria. One is a respiratory criteria that includes the PF ratio, and then a coagulation criteria that's measuring primarily the platelets, and then liver function, measuring bilirubin, and then cardiovascular criteria is the mean arterial pressure or the need for vasopressors. Then the central nervous system criteria is measured according to the Glasgow-Coma scale, and then creatinine and urine output make up the renal function. So of these 6 parameters, you get a score of 0 to 14, and if you have 2 or more, so it doesn't require a lot, just 2 or more, you are considered to have sepsis if these organ dysfunction is from an infection. Okay, so next slide, please. So this person, we don't have any idea for the PF ratio because it was not measured. The bilirubin was also not measured, but we know platelet count is about 30,000 score for that. Patient's mean arterial pressure is normal, so they get a 0 score for the cardiovascular. But patient's mental status is not normal, so I would get a 1 point for a GCS of 14, and then creatinine is at 2.0, so you get 2 points according to this scheme. So you basically need a table like this or an app that helps you, because no one's going to remember this complicated table on their own. But once you have a table of this kind, it's not that hard to use. And so this person would meet the definition of sepsis, but not the septic shock according to the new definitions. Next slide, please. Because, I'm sorry, the one back. So because the SOFA table is complicated, they also have something called a Q-SOFA, which means a quick SOFA score. And so they simplified these things into just 3 criteria that's fairly easy to remember. One is a change in mental status. Second is a respiratory rate greater than 22. And third is a systolic blood pressure less than 100. So this patient, if you remember, had some confusion and had a respiratory rate of 24. So this person would meet 2 of the 3 criteria for Q-SOFA. And that's an easier way to score the organ dysfunction rather than the formal SOFA score. Excuse me. So what's officially recommended according to the Sepsis 3 guidelines is that in the ICU setting and also in resource-rich areas, like in many parts in the US, you use a formal SOFA calculation according to the table I just shared with you. But in the pre-field setting or in the emergency room, or perhaps in the low income countries where not all of these laboratory measurements are made, you can use the Q-SOFA score. Next slide, please. Now, this new definition everyone should know, but it's kind of controversial for a couple of reasons. One is, it is certainly more complex than the old definition. If you look to the graph on the right, those four colored markers are scoring the area of the receiver operating curve for prediction of mortality for these four scoring schemes: the old SIRS definition, the new SOFA definition, the new Q-SOFA definition, as well as a more sophisticated measure called the Logistics of Organ Dysfunction score, or the LOD score. Basically what this means is, if something is above 1, it's a perfect predictor. If something is 0.5, it's random, and so not a very good predictor. So as you can see, the SIRS is the one that performs least accurately among the four options. But the problem is, the SOFA is still not as good as the LOD score, and LOD score has been abandoned because it was thought to be too complex. In other words, they're using the SOFA score because they're saying the SOFA score is a, excuse me for a second, because they're saying that the SOFA score is simpler to use than the LOD score, but you could make the same argument for the SIRS score. So it is marginally better, but it's not clear that it's worth the complexity in some people's opinions. The other controversy is particularly for the low and middle income countries where not all of these tests are done or even available. So there are a lot of people around the world who are trying to weigh whether these new definitions are actually useful, and I think that controversy is going to continue for a while. At least for the low and middle income countries, you can probably use the Q-SOFA score rather than the formal SOFA score, because as you can see from the area of the receiver operating curve data, they are fairly similar between Q-SOFA and SOFA. Okay, next slide, please. So going back to this clinical scenario, what's important to note is that in the old definition, this person would have met the criteria for severe sepsis. But with a new definition, there is no such thing as severe sepsis anymore, and this person would be categorized as sepsis according to the new Sepsis 3 definition. Next slide, please. Okay, so now I want to focus on the Surviving Sepsis Guidelines from 2016. It was just published, I think, about a month ago, or actually about 2 weeks ago, last month. So next slide, please. So this same patient now has a blood pressure of 85/30. So which of the following will improve his chance of survival? A, albumin. B, blood transfusion to achieve hemoglobin greater than 10. C, choice of norepinephrine over dopamine. D, fluids and vasopressors to target MAP greater than 80 as opposed to 65. E, early goal-directed therapy to achieve a MAP greater than 65, urine output greater than 0.5 mLs per kilogram per hour, central venous pressure greater than 8, and a venous saturation greater than 70%. Or finally, F, none of the above. Next slide, please. So, as I said, the 2016 Surviving Sepsis Guidelines were just published in Critical Care Medicine about 2 weeks ago. And the overall guidelines, there are 93 different recommendations, which is hard to read and follow. So I'm going to focus on the early management as opposed to later management. So this would be the part that's relevant in the first maybe 6 to 8 hours of someone presenting to the emergency room or to a hospital setting. And of the 43 recommendations, 11 of these are considered strong recommendations, and 13 of these are considered best practice recommendations. Strong recommendation means that there is good randomized controlled trial data or good or high level of evidence that supports that we should do these steps. And best practice, there might not necessarily be randomized controlled trial data, but it is the overwhelming consensus of the experts that we should be doing these things. And in fact, they make a comment in their guidelines that these should constitute policy for the hospital, and they can even be used as quality indicators. That is, if you don't do these things, you could be accused of practicing substandard medicine. So these are very important recommendations to be aware of according to these new guidelines. Next slide, please. Now, again, these are 24, so it's a little bit unwieldy, and we don't have time to go into details of all 24. So what I'm going to choose to do for the remainder of the lecture is to summarize these points into 7 major areas. One is in the area of resuscitation. Second is in the choice of fluids. Third is in the choice of blood transfusions and hemoglobin targets. Fourth is in the choice of vasopressors. Fifth is the mean arterial pressure goal. Sixth is in the choice of antibiotic and the timing of antibiotics. And finally, the idea of source identification and control. So these 7 areas is what I hope to go through in the next 15 or 20 minutes. Next slide, please. I think the first concept that is important for anybody who deals with a severe sepsis patient is to be aware of this idea of what is sometimes referred to as the Landry phenomena or Landry hypothesis. This starts from a pretty intriguing animal experiment where they took a group of rats and they actually bled them for 30 minutes. So these rats lost approximately 30% of their circulating blood volume to cause hemorrhagic shock, and they didn't treat them intentionally for the first 30 minutes. After the 30 minutes were over, then they started to resuscitate these rats at different times. So some were immediately resuscitated at the end of the 30 minutes. Others were delayed by 15. Others were delayed by 30, 45, 60, and some rats were not resuscitated at all. So I'm going to highlight those that were immediately resuscitated in dark blue, those who were delayed up to 60 minutes before resuscitation was started in light blue, and then the rats that were not resuscitated in purple. So if you look at the right side of the screen, if you look at the lactates that have accumulated over time, depending on speed of resuscitation, it's pretty obvious to see that delayed resuscitation results in higher level of lactic acidosis, which is very logical because you're not resuscitating, so there is still ongoing hypoperfusion and therefore ischemia and injury to the tissue. And if you look at the bottom right, you can see that inflammatory markers such as interleukin-6 levels also do the exact same thing. That is, delayed resuscitation results in more inflammation. And then if you look at the left center of the screen, you see 5 histological sections of these rats' lungs. So the top left is unresuscitated. So this is essentially your baseline rat lung, which shows fairly normal amounts. But then as you delay resuscitation from immediate to 30 minutes to 45 minutes, and finally to 60 minutes, you can see just even with your eyes that there's substantially more inflammation in the lungs. What you're witnessing is actually ARDS-like phenomena, both in terms of inflammatory markers and cellular infiltration that is happening in the lungs simply due to delayed resuscitation of hemorrhagic shock. So this phenomena has been generalized to say that any shock, whether it's hemorrhagic shock, cardiogenic shock, or even septic shock, if you delay resuscitation, then you're going to result in greater amounts of inflammation, more lactic acidosis, more ARDS, and more lung and other organ dysfunction, which will result in death. Next slide, please. So besides immediate resuscitation, you now have to choose, of course, between fluids and vasoactive medications. So the first topic I want to handle are the fluids. So this is a strong recommendation. And the strong recommendation is that we not use colloids in general, but we use crystalloids. The evidence behind it is shown by these 3 trials. And by the way, for all the trials, I'm going to use the PICO format to describe it. PICO is population that they studied, intervention that they studied, C is for comparison to the intervention, and O is the outcome that they measured. So for example, for the VICEP trial, the population was 537 severe sepsis patients in the ICU. And then intervention they looked at was 10% pentastarch, and they compared it to lactated ringers, and outcome they were measuring was death at 28 days. So as you can see across the table, VICEP trial, the 6S trial, and CHEST trial basically studied some form of starch, some form of a crystalloid fluid like lactated ringers acetate or normal saline, and they measured death either at 28 days or 90 days. I'm going to also try to make a comment about what the quality of these studies are. I don't have time to go into a lot of details, but I will highlight that the last 2 trials, the 6S trial and the CHEST trials, had a very low risk of bias, meaning it's a pretty high quality study. So for these 3 trials, next slide, please, the outcome showed that in general, there was no benefit of using starch over crystalloids. If you look at the mortality, there was not much of a difference, except in the CHEST trial, there was actually evidence of harm by using hetastarch. That is, there was a greater need for renal replacement therapy, or it resulted in a higher mortality. And then finally, all 3 studies show that more renal replacement therapy like dialysis or CVVH was necessary when pentastarch was used. So I think there's pretty compelling evidence that that starch compound should not be used for resuscitation. So hopefully that is not what is happening at your hospital. Next slide, please. Then the other 2 trials is a summary of the use of albumin. Again, using the PICO format, these are ICU patients who got either albumin or some kind of a crystalloid, and then they were looking at death at 28 days. The Albias trial on your right is an interesting one because they tried to give 20% albumin, and they were intentionally trying to raise the albumin to greater than 3, because the thought is it's those who are hypoalbuminemic who's going to benefit the most from the colloids. It's going to actually pull fluid in and be a great volume expander. Again, the Albias trial was a very high quality trial with a low risk of bias. Next slide, please. So again, for these 2 studies, they showed exactly the same results. There was absolutely no difference in mortality. And then in terms of organ failure, again, there was no difference. So if you take a summary of the starch trials and the albumin trials, it suggests that the best fluid is still your cheap and readily available crystalloid fluids like normal saline. And there's no particular reason to use these more expensive colloidal fluids. Next slide, please. The third topic is that of blood transfusions and hemoglobin. So certainly when I was in training, I would get in trouble if I did not transfuse people up to a hemoglobin of about 12 or higher, because it was thought that higher hemoglobin meant higher oxygen carrying capacity, higher oxygen delivery, and then probably improved survival. So these are 2 very different studies that have looked at the hemoglobin targets, and I think they're both worth mentioning. So the first study from the New England Journal in 2013 from Spain took patients with upper GI bleeding, and they randomized them to a hemoglobin target of 9 or higher versus 7 or higher, and they looked at mortality at 45 days. The other study is a TRIST trial, and this is a study of about 998 patients, specifically in septic shock patients with the same hemoglobin target of 9 versus 7, and they looked at death in 90 days. And actually, both of these studies were a fairly high-quality trial, with the exception of the Spanish paper with upper GI bleeding being a single center, which has been empirically shown to be less reliable than multi-center studies. So what did these 2 studies find? First of all, in terms of mortality benefit, so next slide, please. there was actually no difference in mortality for the septic shock paper, that is the TRIS trial, 45% versus 43% with either hemoglobin target. But surprisingly, for the upper GI bleeding population, there was actually a higher risk of death with blood transfusions, and there was also a higher risk of rebleeding. So again, blood is a good idea if you are having maybe exsanguinating situations where you're losing a lot of blood, if you're actively bleeding, but there's certainly no reason to arbitrarily raise your hemoglobin beyond a level of 7. Next slide, please. The fourth topic is which vasopressors to use. If you follow the literature, you could almost find at least one paper or more that supports whatever position you wanted to take about, about norepinephrine being better or norepinephrine being worse. So relatively recently, now in 2008 and 2010, these controversies were subjected finally to a high-quality randomized controlled trial. So the SOAP-2 study in the New England Journal in 2010 compared 1,679 patients with various kinds of shock, some septic, some cardiogenic, some hypovolemic, and they compared norepinephrine versus dopamine as their vasopressor of choice, and they looked at mortality at 28 days. And then VAST trial, they concentrated on sepsis patients who are already on norepinephrine, and they switched half of them to vasopressin, and the other half they continued norepinephrine, and they also looked at outcome of death at 28 days. Both of these are fairly good studies with low risk of bias. Next slide, please. And in both of these studies, there was no difference in mortality between these different comparisons. So in terms of dopamine, norepinephrine, or vasopressin, there does not seem to be a particular advantage of any of these three drugs over one another. However, the one finding in the SOAP-2 study was that there were a lot more arrhythmias with dopamine, especially atrial fibrillation. So the overall consensus is that if you have a choice, norepinephrine may be preferred over over dopamine. And so if all three drugs are available, most people might pick norepinephrine because of fewer side effects. They're all equally effective or not effective in terms of mortality. Okay. Next slide, please. And then the next topic is what should the blood pressure target be? So there's a sepsis spam trial that came out about 2 years ago or so, and they took patients who had septic shock, and they randomized half to a high MAP target of 80 to 85 versus a lower MAP target of 65 to 70. They looked at mortality at 28 days. Again, this is a high-quality study with relatively low risk of bias. And what do they find? Next slide, please. Again, no difference in mortality. So a MAP target that's been traditional at 65 is just as good as higher MAP targets. Next slide, please. Okay, the next topic is now no longer about resuscitation, but more about antibiotics. And the basic idea here is that you want to give antibiotics as soon as possible. So here's some older study from 2006 by Kumar in Critical Care Medicine. This is a retrospective analysis of 2,731 adult septic shock patients. Next slide, please. And as you can see, on the x-axis is the number of hours from the onset of hypotension. And then on the y-axis is your risk of death. So with each hour in delay of appropriate antibiotics, as you can see, the risk of death rises almost linearly. Next slide, please. And in fact, the authors calculate that each hour is associated with an 8% increase in the risk of death. More recently, next slide, another set of authors basically did the same kind of analysis using almost 18,000 adult severe sepsis and septic shock patients. And again, every hour in delay of antibiotics results in a higher risk of death. So I think there's fairly convincing evidence that early antibiotics is very important. Now, neither of these are randomized trials, obviously, and from an ethical point of view, you can't randomize patients to a delayed antibiotic strategy. So this is probably about as good as it's going to get, but it's considered, again, a strong recommendation by the Surviving Sepsis campaign. Next slide, please. Okay, the last area of emphasis is in the idea of source identification and control. So this is just recognizing what is causing this patient to be septic, and then what do you need to do about it. So first thing to note is that there are very, very common sites that cause septic shock. So those are the lungs, urinary tract, abdomen, and in the appropriate setting, central venous catheters that are old. So in most series, lung is the predominant source of severe sepsis or septic shock, and pneumonia is maybe 50 to 60% of patients who are presenting with septic shock. Urinary tract and abdomen follow, and then again, central venous catheters, if you have old indwelling catheters, that could be another source. What's also important to note then is if that's the case, you should be very cautious and you should be very careful when you're evaluating the lungs, the urinary tract, and the abdomen and looking for all central sites. So for example, you want to really make sure that you take a good history about urinary symptoms, abdominal symptoms, and pulmonary symptoms, and you want to make sure that you look at the chest x-ray, urine analysis, and the abdominal exam very carefully, because by far, those are the most common sources or sites of septic shock. What's equally important to note is that there are several areas of the body that can get infected, but they are uncommon sources of septic shock. So the examples include cellulitis, osteomyelitis, decubitus ulcer. And then one thing that's important to note is pneumocystis infections. For example, if somebody comes in with an erythematous leg and it looks like cellulitis, it could be, but it's less likely that cellulitis is causing the septic shock than something either in the lungs, the urinary tract, abdomen, or central venous catheters. And if you don't find a source in those four sites, the lungs, urinary tract, abdomen, and central venous catheters, then you might want to look deeper to say, well, maybe it's not just cellulitis, but maybe it's a necrotizing fasciitis, something deeper. And then on a similar note, pneumocystis carinii it's not an uncommon infection in patients who are immunocompromised, such as those with HIV infection, but it is a very unusual cause of septic shock. So if you put the diagnosis of septic shock and then PCP pneumonia, it's probably not the correct diagnosis. So if you have somebody who is requiring vasopressors on, with a diagnosis of PCP, then it's actually worthy of a case report because it's not very common. And then, of course, there are certain sites that require more than just antibiotics. So, for example, if you have pneumonia, the source control means giving the correct antibiotic. But, of course, there are sites that need more than antibiotics, so you should be looking for those. Those include parapneumatic effusions that need a chest tube, necrotizing fasciitis, as I mentioned, that might need surgery, abscesses that may need to be drained, perforated viscus, and then infected catheters that need to be removed. So those are examples of source control besides antibiotics. Okay, next topic. The final topic is to make sure that people who may not have kept up with the literature for the past few years, that this old idea of early goal-directed therapy, popularized by Manny Rivers in 2001, is no longer supported by the current literature. So this is a paper of only 263 severe sepsis patients, and they compared a pretty complicated protocol where they tried to achieve within 6 hours a good blood a good blood pressure defined as greater than 65, good CBP as being higher than 8, good urine output, and good SpO2 saturation. And they compared it to usual care within 6 hours, and they looked at hospital mortality. What did they find? Next study. Next slide, is that they found a substantially lower risk of mortality with the early goal-directed therapy. It was 30% with early goal-directed therapy versus 46% for the comparison. But as you can see from the risk of bias area, it was not the highest quality study. The study did not register itself because this is well before that being a standard. And this was a single center study as opposed to a multi-center study. There were some strong conflicts of interest because many of the study authors, as well as the institution itself, had industry ties. And then besides the protocol of early goal-directed therapy and so forth, patients may not have been treated equally because this was not a blinded situation. Next slide, please. So because of the controversy and the potential weaknesses of the trial, more recently, in the last 2 or 3 years, there's now been 3 much larger, much better designed studies. One is called a process trial, the other one's called a RISE trial, third is called PROMISE trial, and they occurred all over the world, including the US, UK, Australia, and several other sites. And basically, they all compared some version of early goal-directed therapy versus either usual or non-protocolized care. And they looked at mortality as their primary outcome. These were all very high-quality, low-risk of bias trials. And what did they find? Next slide, please. Is absolutely no differences in mortality. So despite the early enthusiasm for early goal-directed therapy, I think people have now confirmed that that is not a valid strategy. So there's no reason to buy expensive catheters that measure SV saturation, or to even measure CVPs, and to target these arbitrary goals anymore. Next slide, please. So going back to our patient who is in hypotensive shock from sepsis, this is septic shock. As we said, albumin is not necessarily harmful, but it is not superior to normal saline or lactated ringers, so that is not necessarily indicated in terms of improving survival. B, in terms of blood transfusion, the hemoglobin target should be 7, not 10. C, norepinephrine, dopamine, or vasopressin are all equivalent in terms of survival, although norepinephrine may be preferred over dopamine in terms of complications because there's fewer episodes of arrhythmia associated with norepinephrine. And then as far as fluids and vasopressors, the target for MAP should be 65, not greater than 80, because it is not better. And then finally, early goal-directed therapy has not been shown to improve survival. So the correct answer is none of these things, other than just basically sound basic care, which is early antibiotics and early resuscitation. Next slide, please. So to summarize, the following are the major points from the new guidelines. Next slide, please. One is resuscitation should be started immediately, and this is a best practice guideline. And then second, IV fluids and or vasopressors is generally indicated to achieve a MAP goal greater than 65, because higher MAP targets do not improve clinical outcome. This is a strong recommendation. Next is crystalloid, like normal saline or lactated ringers, rather than colloids like albumin or starch, should be initially used for resuscitation. Again, a strong recommendation. Hemoglobin targets should be greater than 7, because higher hemoglobin targets do not improve clinical outcome. That's also a strong recommendation. And then among dopamine, norepinephrine, or vasopressin, there is no survival advantage with the use of one vasopressor or another. However, norepinephrine may be preferred over dopamine because of fewer side effects, and that's, again, a strong recommendation. And then appropriate broad-spectrum IV antibiotics should be started as soon as possible. And as you saw from those graphs, even hours may make a difference, so as soon as possible. And again, that's a strong recommendation. And then the source of the sepsis should be identified and controlled as soon as possible, and that's a best practice guideline rather than a strong recommendation. But basically, remember, the lungs, abdomen, and urine and central lines are your most important sources. Next slide, please. Okay.
Go ahead.
And then, sorry. And then I think this is the last part, which is that targeting arbitrary goals or actually adhering to any specific protocols like the early goal-directed therapy that does not seem to offer any clinical advantages over usual care. The next. I think to summarize even these 8 points even more simply, it basically says resuscitate early, give appropriate antibiotics early, and then source identify, and then control the source early. And again, this is basically very good news for low and middle income countries or in the international health setting, because you can theoretically provide the same level of excellent care that you do in the United States as you can in sub-Saharan Africa or in Asia, because most of this is quite doable in the low and middle income country setting. Okay, and that's it.
Great. Thank you so much, Dr. Lee. This was a really great presentation, and really appreciate you taking time to share these new guidelines with us. If you have questions, please post them in the box. I do have a few for you already, Dr. Lee, so we'll start with those, but please note to the rest of the audience, you can post your questions and should post them now if you would like to make a comment for Dr. Lee. So the first question we have for you, Dr. Lee, is why did they get rid of SIRS? SIRS seemed like a good way to recognize the early possible sepsis for an earlier intervention. Can you speak to that?
Sure. The primary argument that's given for getting rid of it is that it's not as accurate as the newer criteria. So that's the summary. But if you remember from my discussion, how less accurate is what's controversial. It is less accurate, but whatever accuracy you gain, you also become a lot more complex with the new SOFA tables. So that's part of the controversy. But to give you a practical example, they looked at patients who they think are clearly in septic shock. There's very little doubt clinically that they're in septic shock. They may even have a positive blood culture, for example, with the usual pathogen. But when they look back at the SIRS criteria, it's possible for you to have no fever. And I'm sure we've seen that clinically. So that's where the controversy comes in, is to say, you know what, these parameters may not be as helpful as we thought. So that's what prompted the change. But like I said, the controversy is the newer definition with its added complexity worth the worth the gain in the accuracy?
Thank you so much. Your next question is from Samuel, and he says, doesn't the lactate of 6 in your case meet the definition of septic shock under the new definition?
No, because, and that's another controversy, is that you have to have both. You have to have both hypotension and shock with a new definition. The old definition, lactate was what got you to the severe sepsis category, but and it was simply the blood pressure criteria that was used. But now you have to have both an elevated lactate and a vasopressor dependence.
Great, thank you. Another question from our audience. For treatment, is there any difference between LR and normal saline for resuscitation? Is there any reason to place a CVC in sepsis patients, or are A-lines the only invasive monitors needed?
So it sounds like a multi-part question there. So let me start with the lactated ringers and the normal saline. So there's no good study that says that one type of crystalloid fluid is better than the other. So it might come down to what's available in your institution or what's cheaper of the two, and they're generally not that expensive either way, but it may come down to preference. There is a physiologic rationale for sometimes using lactated ringers, in that it is less likely to cause non-GAP metabolic acidosis that is associated with fluid resuscitation. So it's kind of at the level of preference versus some physiologic rationale, but there's not any good evidence in terms of mortality or important clinical outcomes that says you should use one over the other.
Great.
And then there was another part to it, but I've forgotten what.
Yeah, I can read it to you. Is there any reason to place a CVC in sepsis patients, or are A-lines the only invasive monitor needed?
Yeah, so that's a great question, and that's also a controversial topic. So certainly in most ICUs in the US that I'm aware of, I think a central line and an arterial line would be considered standard care for somebody who is requiring vasopressors.
Mm-hmm.
So the central line allows you to give the vasopressors safely, and then arterial line, of course, allows you to monitor the blood pressure and to titrate that vasopressor on a minute-to-minute basis. So that is clearly the standard care in most ICUs that I'm aware of. Now, having said that, when I was working at Kajabi Hospital in Kenya, that was not the standard, mainly because of cost and practical considerations. We hardly put in central lines, and we rarely ever put in arterial lines. And the amount of complications that we got from that wasn't very high. So we hardly saw things like tissue infiltration or like digital necrosis. So it's probably a lot safer than we had thought based on our practice patterns in the US. And then more recently, now there is a paper from the West that's confirming that observation, that when they look at a Western ICU and you look at people who receive vasopressors through a peripheral line, again, the complications were not as high as we've been told. So I think there is some justification for not doing it. Now, I say that cautiously because if you're in an institution where that's standard care, I'm not saying you should therefore abandon your policy at your institution. But I think in terms of scientific evidence, I think it calls into question how many central lines we place. So for example, here at Pitt, there's a big concern over central line infections, and so we're constantly telling them to put it up, like to pull out the central lines if you don't need it, which is good advice. But perhaps as more studies are done, maybe you could argue that you didn't need to put it in the first place, which would be even better in terms of infection risks.
Mm-hmm. Thank you. Now, if you could answer this question for us, if norepi alone isn't maintaining the MAP, what is your preferred sequence of utilizing other vasopressors?
Mm-hmm. Yeah, again, that would be mostly a matter of preference as well. And I think if you ask, 5 different intensivists, you're going to get 10 different answers here because there's really no standard. But my personal bias is if a catecholamine vasopressor is not working, that is, let's say norepinephrine, dopamine, or phenylephrine is not working, my personal preference is to add a different agent that is a non-catecholamine vasopressor. So the one that's most readily available is vasopressin. So I tend to use vasopressin when patients are refractory to the catecholamine vasopressors like norepinephrine. Other places, they actually add epinephrine to that. So they're basically adding a very potent a catecholamine on top of the norepinephrine. So it's really depends on your philosophy and your local institutional preferences. I don't think any of this is really evidence-based, however.
Thank you. And our final question today for you, Dr. Lee, is Dr. Brulito, it looks like, is asking, in my hospital, residents assume a high lactate in a hypotensive patient means sepsis. Am I right to teach that elevated lactate is not specific to sepsis and could be due to any cause of shock?
Oh, absolutely. I think that's an important point. So I think traditionally, when somebody has an elevated lactate, we tend to divide it into what's called type A lactic acidosis versus type B lactic acidosis. So if you recall, type A is lactic acidosis that results from some type of hypoperfusion or shock. And then in that list is sepsis, but you can also have lactic acidosis from hemorrhagic shock. You can also have lactic acidosis from cardiogenic shock, or you can have, like for example, mesenteric ischemia and dead gut, and that will also cause lactic acidosis. So certainly sepsis is not the only cause of lactic acidosis. So in a typical ICU, you don't want to assume that it's always from sepsis, although sepsis is one of the more common causes of shock in the ICU, obviously. And then finally, there's also another cause of lactic acidosis called type B lactic acidosis, and that's often associated with certain toxins, like, for example, cyanide poisoning, as well as liver dysfunction, kidney dysfunction, even seizures and exercise can cause lactic acidosis. So not all of those are benign. Like, for example, cyanide poisoning, you could obviously die from as well. So they can be serious, but type B is lactic acidosis that is not associated with shock or hypoperfusion state. So it's a totally different mechanism altogether.
Great. Well, thanks again, Dr. Lee, for teaching us and being willing to participate in today's forum. And thank you to all of you who participated in today's webinar and for the great discussion. I feel like we've learned a lot, so I appreciate you taking time out of your busy schedules to be part of this. I want to just remind you that CME is available for this session. So if you will just follow the instructions in your email, they'll be sending out a follow-up email with these instructions and on how to get CME. So just follow the instructions and you'll be able to receive that. If you are not on our email listserv and you would like to be on that, just click on the Join the Forum at health@samaritanspurse.org, and you'll be the first to know about our upcoming events. Along those lines, on March 8th, Dr. Steve Haverly will be presenting at our next Samaritans Purse International Health Forum webinar, and he will be giving an update on cholera. So we hope you will join us for that as well. Thanks again for your time and your participation. We hope you have a great afternoon.
Thank you very much.
Thanks.